is going to be talking about Atmosphere, a project on. So she is a senior lecturer and a deputy director of the Digital Health Research Group and the director of the CDT in Digital Health and Care. And she did her PhD at Bristol, focused on chronic health conditions in younger children. And she's also a childhood health psychologist. And her research interests include AI in health technologies. So that's things like epilepsy, seizure forecasting, skin disease diagnosis with computer vision, and lifestyle modifications using LLMs. So without further ado, take it away.
Yeah, thanks very much for the introduction, Matt. Yeah, today I'll be focusing on providing the methodological background and some early results from the Atmosphere project, which is looking at using artificial intelligence to optimise seizure prediction to empower people with epilepsy. And just to note that although today's seminar is going to be focused on this one case around AI for enhancing epilepsy care, this is kind of one example of a digital health intervention or an AI-driven intervention that's happening within the Digital Health Research Group. So you may recognise some faces from the slide. So although it's focused on one case study, the idea is that the methods behind this project are generalisable to similar kind of health technologies. So, for example, within our research group, Matt is focused on decision support tools in the NHS clinical workflows. Emily's looking at using mobile technology and clinical decision support around skin NTDs. We've also got Samuel who's looking at using LLMs to give clinical decision support for more public health contexts. So just to say, although the methods I'll be describing are related to the epilepsy project, they're more generalisable to any of these kind of technologies where there's an AI component or data analytics component, but they're being in systems with end users needing to engage with model outputs. So that could be clinical end users or it could be patient end users. They might be using this within NHS setting or real world contexts. And because of those complexities in the end users and the workflows or real life situations that they're being used within, this makes it really essential for kind of user-centered design methods. So it's not just about the fundamental engineering challenges of like the hardware or the interface design or the data analytics. It's really how users are going to use this in their context that's going to create clinical impact. And because of that, so thinking about those three examples that I gave and also the epilepsy project, which I'm going to go into more detail about, these kind of systems that we're commonly developing within our group kind of have three core components. So there's something about data collection from the patient or the client or the person with the clinical need. So that's capturing using things like mobile tech.
Like say she had whatever.
Sometimes that's real-time continuous data. Sometimes that might be like a static snapshot of data. For example, in the skin NTD case, it's taking an image of a skin lesion. There's then some kind of data processing. So more and more this is AI approaches and machine learning that we'll talk about in our project. And then there's presenting the outputs from this data analytics to the end user. And obviously there's a lot of like foundational engineering questions within all these components. But really within our group, we focus on a lot on thinking about a social ecological model or complex intervention models where you're really thinking about the end users and the complex systems that they're being used within. So for example, when we think about the individual with the health condition, it's not just like, can you collect accurate data from the person, which is kind of like the engineering challenge. It's actually, is the system usable within their real world environment for an extended period of time? Is it meaningful? So there are things that are features that are meaningful to you as a research team, but there may be additional features that you want to put in that make it more meaningful and engaging to them. And also it's not just about, can you solve the engineering challenge of can you capture the data? It's how can that be translated into clinical meaningful outcomes for that individual? You may also be considering wider system issues around like families, friends and carers. So often in health contexts, carers are a big part of the role of managing a health condition. And it's important that you're designing technology to reflect this and include those other people within the healthcare system. You also may be thinking about integrating with the clinical workflows. And again, this isn't just the engineering challenge of like, can you make it interoperable? This is how can you present the data so that a clinician can use it within a fast-paced clinic? Are they happy to take the responsibility for AI outputs? How can they have clinical oversight to manage any risks? So those kind of wider clinical issues. And then at the highest level of the socio-ecological model, you're also thinking more about kind of society level and policy level issues. So commonly, these kind of technologies will be regulated as medical devices. So you have to think about designing them not just for the end user needs and not just with the optimal technology, but also how they can meet ethical and regulatory standards. And also thinking about wider societal issues, like, for example, health inequalities. We know that's but for health in general, those from certain underrepresented groups take a lot of health burden, and it's those groups that are often digitally excluded, so they might not have the latest technology or they might not be as technologically literate. And so there are risks that by designing these kind of newer wave technologies, you could be excluding those most in need. So it's those kind of higher level things that you need to consider when designing these technologies as well. And kind of mapping onto that idea of like, there's the engineering challenges, but there are other kind of complex challenges as well. I really wanted to highlight that although I'm presenting here today, this epilepsy seizure forecasting technology is the project's been very interdisciplinary and has had a lot of people with a lot of different backgrounds and expertise to make sure that we're able to explore all those different challenges. So of course, we've got kind of people working on the maths and the data science, but we've also got people working on the HCI components around the design of the interfaces and how we capture the technology. We've got people more with backgrounds in health sciences and clinical expertise. We've had patient partners involved in the project, software developers. We've also consulted with people around the legal and regulatory side of things, and also had industry partners involved. So yeah, when you're thinking about these complex systems, that kind of interdisciplinary approach is really important. So going into the specifics of the epilepsy seizure forecasting technology, so just a very quick background on epilepsy. So epilepsy is characterised by recurrent seizures caused by excessive electrical activity in the brain. It is the most common neurological condition. There's about 50 million people worldwide that experience epilepsy, and in the UK, it's around 600,000. So it's a common condition. But the thing with epilepsy, it's a really impactful condition. So those living with epilepsy, there's a significant burden. So it's actually associated with premature death. There's a condition called SUDEP, which is unexpected death related to epilepsy. People with epilepsy experience much higher rates of injury. So when you're having kind of a tonic-clonic seizure, there can be lots of serious incidents that happen with that, leading to A&E admissions, and like impacting life quite significantly with the injury and harm. There's also more the mental health impact and quality of life impact. If you're experiencing uncontrolled seizures, it can really impact your ability to work, ability to travel, can impact family life. So it really places a high burden on the individual living with epilepsy. And we also know it places a high burden on the NHS, both with increased GP appointments, obviously accessing specialist epilepsy care, and also higher rates of A&E admissions related to those kind of acute injuries and harms. And for epilepsy, so there's a national initiative called Priority Setting Partnerships. This is not just an epilepsy specific thing. So it's run by the NIHR and the James Lind Alliance. And for a lot of clinical conditions, this is the gold standard for identifying what are the key research priorities for any given health condition. So this really helps make sure that funding is going to the critical issues for any given condition. It involves nationwide consultation with clinicians, patients, charities, kind of any key stakeholders. And for the Epilepsy Priority Setting Partnership, at number 6 in the top 10 research priorities was that stakeholders really identified a need for tools and technologies to help with the prediction of seizure. So it's really living with that unpredictability, not knowing when you're going to have a seizure next, that can be one of the most impactful elements of living with epilepsy, creating one of the biggest burdens. And speaking to stakeholders, if this challenge were to be solved, so if we could give people with epilepsy some kind of tool that gave them some kind of early warning sign or prediction or forecasting tool, there will potential for clinical outcomes for the individual with epilepsy. So as mentioned in the previous slide, those acute injuries and harms are really elevated in people with living with epilepsy. And if you had an early warning sign, there would be ways that you could manage that acute risk. So you can alert carers, you can avoid certain activities that have increased harm, you can maybe stay indoors in high-risk days, and also it can guide the use of emergency medications, which can they're really heavy duty, so you can't take them all the time. They're highly sedating, but they can have a fast acting effect on seizures. So it could also guide that, which would increase kind of reduce harms and kind of increase safety management around seizure. It could actually also lead to improved seizure control, because one of the things that these types of technologies can do, as well as giving a forecast, it can give individuals personalised information about the triggers driving seizures. And if you have more information about factors that you can take control over, then it actually gives the ability to improve seizure control and reduce seizure frequency. And all those kind of not softer outcomes, but the outcomes related to quality of life. So on low risk days, being able to engage in valued activities, living with the uncertainty is just a major mental health toll. So if you can reduce some of that uncertainty, it can improve quality of life, and as well as enhancing a sense of control, which we call locus of control. So our team came together to try and solve this challenge around designing tools for seizure forecasting. And it's really underpinned by the existing scientific knowledge that seizures aren't entirely random, and actually seizure risk increases under certain conditions. So it's very well established in the literature. There are certain variables such as stress, certain phases of the menstrual cycle, sleep deprivation, alcohol intake. These are all factors that are known precipitants to seizure or seizure triggers, so they elevate the risk or likelihood of seizure. So our technology is really based around this kind of fundamental science. And from this, we designed a technology. This image might look similar to the one I was showing earlier, where you're using mobile technology to collect real-time or continuous data on those known seizure triggers or seizure precipitants, along with labels of seizure events. So that's longitudinally and in people's real world context, collecting this real-time data. It's then using machine learning to do under predictive analytics to create risk scores for the likelihood of seizure in the near future. And also machine learning approaches called feature importance, which also tell you about which factors are driving that risk score. So a person's not just presented with an elevated, like it's not just saying you've got a high risk of seizure today. It's actually giving some sense of, well, that was because of missed medication, or it was because of a poor night's sleep, or it's because of elevated stress. So they're actually learning about what precipitants for them are driving elevated risk scores. And then the information from the modelling is presented back on a companion app. So again, they're given information on forecasts, trigger insights, as well as other accompanying self-management support to help them manage some of those risks. So just going into some of the, so today, although I talked about this being an interdisciplinary project, I'm very much focused on the user-centred designs that we use to create to start developing and evaluating this technology. We did divide it into those 3 core components initially. So we were kind of working separately on 3 work streams. One was about designing and optimizing the data collection component. one was about the data science and machine learning, and then the third was about designing the app interface. So we kind of, although there was close collaboration between the teams, we kind of separated those into 3 different work packages. And I'm going to go through the methods through each of the components, but really show why the user-centered design and HCI approaches were so critical in making these, kind of refining them and optimizing them. So thinking about that first component of how do we collect this longitudinal real-time data for users that enables this technology, we drew on the complex interventions framework and the person-based approach by Lucy Yardley to really work with users to design a system that was going to be feasible over the long term. So for the first phase, it was going into co-design sessions with individuals. So I call this kind of lab-based, but we brought people in who had experience of living with epilepsy, and we knew what variables we needed to collect from a scientific point of view. But these initial co-designs were really finding out, okay, we know we want to collect sleep, alcohol, menstrual cycle. We know this long list of variables that we want to collect from you. But as someone living with epilepsy, is this actually acceptable? Would you be happy with us tracking all this data over the long term? And then also going, once we knew what variables were acceptable to collect, it was then designing the best way to collect those through mobile technology and a companion app. And I guess the key finding was that people were like, yes, collect all the data and more. People were like, if they felt like they were going to get this valuable outcome of a seizure forecast, then they were very happy for this level of data to be collected. And they were making lots of suggestions for kind of personalised tracking and co-tracking. So they were very keen on the data being collected. Though some people did make suggestions around customisation, so being able to turn on and off certain data points and to give people a sense of kind of autonomy and control around that data tracking. So once we knew what items we needed to collect, we then started designing the wording for the app to make sure that it made sense, that we weren't using lots of technical language that people didn't understand, to make sure it was like as short as possible, because we need to balance like the richness of data along with what's possible for people to provide us with on a daily basis. So we did lots of design around which questions and the content of those questions within the setting. And from that, so within the kind of iterative phases, we were using like PowerPoints to like suggest different wording types and different visuals. But once we had our final list of questions that we wanted to include, from this we developed mid-fidelity or functional prototypes. So we worked with a third-party app integrated with a Garmin, and we could then take all the questions that we designed in the lab and put this into the third-party app. So the technology is that people wear the Garmin device and then they get prompts to complete a survey during the day, twice a day, on kind of user like data points that need to be manually entered that can't be captured passively from the device. And so once we had our prototype, we then deployed that in the wild. So this was giving it to users to use in their own real world environment. Initially, we were going to do it for a month, but we extended that up to 6 months. So we did this in waves. So we gave it to 5 users. We collected mixed methods data, so quantitative data about usage, how often they were wearing a smartwatch, how often they responded to the surveys. We then, at the end of the 1 month period, spoke to users to find out about what worked, what didn't. Were there questions that were kind of hard to understand? Was it too long? Were there additional questions that they would like to answer? And then we used that mixed method data to refine the prototype and then redeploy with a further 5 users. And we did 3 rounds of that. We ended 15 in total. We ended up recruiting 14 in the end. But from that, we ended up with a refined functional prototype. So we kind of optimized it each time to make it more usable in the long run. And one thing I would mention here is something that we really wanted to prioritize was often projects spend a really long period in co-designs, like doing long series of workshops in co-design, which is great. You can get like loads and loads of important information from your users. But one thing we wanted to do in this project was move quite quickly from co-design to real world deployment, because quite often what people say they want in the lab is quite different to how it's actually experienced in the real world. Like people said they wanted to track, they gave us so many data points on what they wanted to track, But when it actually comes to you using this technology, when you know, rushing to work, or like you're dashing about, or like you're sleeping in, it's often not how you anticipate using it. So it's really important that we got that kind of real world feedback as quickly as possible. And the other reason why we wanted to move to in the world deployment as quickly as possible is because it started to allow us to have a data stream coming in that we could then share with the data science team. So that was kind of another benefit of moving to prototype much quicker than some projects typically do. So from that, we've been working with we gave the refined functional prototypes to our software developers, and they started developing their MVP, so the fully developed system of this data collection component. And we did this with, so they were going through a sprint of development. We then took it for user testing. And in this phase, when we took user testing, we actually did some mock-ups in Figma. So this is just a software for very quickly doing some like visuals, which you can do much quicker than in full software development. So we'd check out our refined designs with users in Figma before then feeding it back to the development team. And again, this just kind of makes it a kind of quicker, agile process where you can test out a range of designs and get feedback before kind of like making more final development decisions. So from that, we have our fully functioning, we will have our fully functioning app for the data collection component integrated with a Garmin. And the idea is that we'll then take this into an NHS study with a larger sample of people, where we'll continue to collect mixed method data about usability, and we can refine our version, so our MVP, ready for integration with that algorithm in an interface eventually, which are the other two work streams. Am I right for time? Yeah, oh yeah, I'll come back. So alongside, so in our project, we set up the work streams to work in parallel. So we didn't make them dependent. We didn't kind of do a waterfall design where we wanted to wait to complete all the machine learning before completing the interface design, or we didn't want to completely wait until data collection was complete until we started the data science. We wanted it running all in parallel so we could feed into each other's work streams and have like quite an agile way of working. So in parallel with the data collection component, the data science team were working on the machine learning and data analytics component. And obviously one of the problems is that when you're in our very earliest stages, when we were just doing co-design in the lab, we didn't have any data for the data scientists to work on. So obviously that seems like a very big problem. So, but what they started doing is they started working with synthetic data sets. So there was a open access data set called Chocolates, which models, it has realistic seizure diaries. So it's based on thousands of patients' data. It has seizure diary data. And then they use this to create synthetic data sets of the relationship between seizures and the seizure triggers. So this is not based on our data structures. So it wasn't based on how the data looks from our wearable and app, but on a higher level, it models the relationships between stress and seizure, or sleep and seizure. So they use those synthetic data sets to set up this their own data set, having a realistic relationship between the seizures, which are marked in red, and then the precipitants that we will be using in our technology. And then they initially trained an algorithm on this synthetic data set. So this is just a few of the precipitants. So in seizures, as well as the ones I mentioned, there's actually a cyclical pattern to seizures. So there's like a circadian rhythm where for different people, there'll be certain times in the day where they have increased risk. So they kind of model the circadian rhythms. The blue is related to sleep pressure. So at the bottom here, this is where someone has slept overnight. Then when they wake up, there's kind of increased sleep pressure throughout the day until they go to sleep again at night, and the sleep pressure drops. So they model that, and you can see in this initial time series section, they're having kind of very regular sleep patterns. So this is how they kind of modelled out the precipitants. And then they trained the algorithm, and you can see here, so this is where someone starts having disturbed sleep. So there's an elevated sleep pressure score. And you can see that this is where the algorithm is starting to predict elevated risk of seizure. And then you can see this is where someone did actually have a seizure in the data. So you can see there's kind of like, it's kind of detecting seizure in the risk score algorithm. So this was helpful to set up like a framework for how we would work with precipitants and develop the algorithm. But the key problem was that this does not reflect the data that's actually coming in through our technology, because at the point of co-design, we didn't have that yet. So that was one of the reasons why we wanted to get into that in the world deployment as quickly as possible. We could start transferring data from that data collection component over to the data science team, so they could start translating the algorithm into the final structure of the data. So that was one benefit of doing that early, that it would kind of help with the modelling. The other reason why it was really helpful to get that data over to the data scientists as soon as possible, because as well as user requirements, when the data scientists started looking at the data set, they also had requirements for how the data was being gathered, that they could start feeding back. Hang on, it's really not helpful to collect the data in this way, like the framing of your question gives us data that's a bit useless, or could you frame it in this way, or could you use a different scale? And that helped us when we were still in that prototyping stage. We could take all their feedback and actually refine the surveys to make it more meaningful for them and for their analysis. So as an example of this, when we spoke to users, when we were designing the questions about around how to capture seizure, the users came up with the idea of having 1 to 2 hour window. They were saying then they're often not certain of when they've had their seizure because of cognitive impairment. It's often hard to pinpoint the exact moment in the day that they've had the seizure. So users suggested having a button to report a seizure, and then there's a drop down menu where they have like 2 hour windows to say, yeah, I think it happened 1 to 2 hours ago or 2 to 4 hours ago. And also they really wanted an unsure or unknown button, because they say often it is really hard to remember. So that's the way that we'd set it up in the prototype. But once the data scientists had that data, they really fed back that that was a very, very unhelpful way. You're probably thinking, yeah, that's obvious, but that's a really unhelpful way for them to have the data, because 2 hours is a really wide window of uncertainty, and actually having an unsure button where you have no sense of the timing means that the data can't be used at all. So we worked with the data scientists on that, and they suggested having a drop down where people can put the exact time. And then they then have a second question where they measure, they basically then put their uncertainty, and they have to put a score into there. So they can say, I think it happened at 8 a.m. and I'm sure to within 10 minutes, or I'm sure to within 20 minutes. So they've got a lot more granular data about the timing with a measure of uncertainty rather than having the completely unknown option. So it was kind of like what seemed like small decisions to us actually become a bigger problem when you're working with the data science team. So it's really good to have that like back and forth, but they're seeing the data sets very early on, so you can still make those changes. So that's kind of the how user and HCI approaches informed the data science element. And then thinking about that third component about the interface design, obviously this is absolutely critical to have user involvement in designing how the models of the AI outputs are going to look. So again, we did quite an iterative process of design. So we brought people in for initial co-design to understand what were the key features that they needed for the app, not just the forecasting, what additional features did they want there to help them with kind of self-management support. We did iterative designs, again in Figma. So we used this software where we could mock up designs of the app interface. We'd get user feedback, refine them in an iterative manner. And then once we were kind of happy with those initial designs, we started going into, which we're doing now, is one-to-one interviews. So we're getting people, we're presenting the visuals and doing a bit of a deep dive into exploring things like interpretability. So do they understand what we're trying to communicate with the risk score? If we're presenting a high risk score, is that how people are reading it, or are they reading something else? Understanding the explainability. So do they understand why the risk score is saying what it does? We were also really keen to explore the emotional impact of how we were presenting back seizures, because one of the precipitants or triggers to seizure is stress and anxiety. So we did really want to think about, if we were, you know, displaying these with like alarm signals and sirens and then flashing red, that could actually just elevate stress by presenting that forecast, which would then have a feedback loop to present potentially triggering a seizure. So we really wanted to explore how people were like experiencing this emotionally as well. And also alongside the images of the forecast, we wanted to know what self-management support they need alongside this, because it's not enough just to have a forecast that people understand. It's the what next. How does this actually translate to them taking action to manage risk or to manage their triggers? So that's like a really important part of it as well. And also trying to communicate the complexity of these models to people. So trying to communicate things like uncertainty, or that the model is only as accurate as the underlying data. And if you've not been wearing the watch overnight, then the model will be limited in this way. So it's not just presenting the forecast, it's about presenting all the caveats around that as well. And these are some examples from our kind of earlier forecasting designs, which we've been getting feedback on. So just thinking about those 3 work streams and why user-centered design has really shaped the technology. It wasn't like a tick box exercise where we could just say, yeah, we've consulted with users, but we kind of knew how we were going to design it anyway. This really just summarises how involving users has made a technology which is more feasible for users in their real world environment, how it's tried to include features that we didn't initially think of, but hopefully make it more meaningful and valuable to them, and also how it's designed now with hopefully that will really affect those clinical outcomes. So not just thinking about can we get the most accurate model, but how does this translate to better seizure control or better risk management? So with the data collection component and the patient app, some of the things we learned were that quick and easy reporting of seizures is essential. That might seem really obvious, but within the initial co-design, people were telling us about these reams of data that they wanted to collect about seizure. So they wanted to collect if they had a seizure, the timing of the seizure, what type of seizure it was, whether it's tonic-clonic, whether it's absence, whether it was a cluster, so whether it was a single event or if it was like 5 in a row, the time differences between the clusters, if it transitioned from one seizure type to another, the symptoms they were having beforehand, the symptoms they were having after. They told us they wanted to collect all this data on each seizure. But then when people actually go to use it in real life, you might be surprised to learn that actually they don't want to spend all day, every day, like completing these massive surveys. And actually what is really important is to have functions where you can just, especially just after you've had a seizure, you often have cognitive impairment and memory problems and confusion. So just having something where you can tap one button or use voice reporting can be really helpful just to capture that seizure event, and then with the opportunity to later on add in all that additional information that people want to track. There's an option to do that, but in the moment just having functions to enable quick reporting was really important. And yeah, thinking about the impact of cognitive impairment, people suggested things like co-tracking, so a relative or a loved one or a carer can also have a version of the app so they can help input data on that individual as well. But crucially, although people did like this idea, they still emphasise the importance of autonomy and control. So they select who can track, they can select which data points. So someone might be happy with them tracking their medication and seizures, but they might not be happy with co-tracking on like mood or alcohol or something like that. So they can actually select the exact data points for a co-tracker to report. And things like having visual prompts of the data they already have put in, because people were saying that they would log a seizure, but then because of cognitive impairment, they would often forget if they had logged that or not. So they wanted the visual feedback of knowing if they had already logged a seizure that day, and they can see that in the diary. And then, yeah, one of the things that came out was that although at the beginning we were really focused on seizure forecast, so this risk score that would help with risk planning, something that was even more valuable to people as a feature in the app was actually the personalised triggers. So with a risk score, you have limited control over what you can do. You kind of just get this risk score and you have to kind of reactively just respond to that for acute management. But what people were saying is actually understanding the personalised triggers that drive elevated risk really gives you a sense of like control to understand your condition better and to be able to take action to actually reduce seizure risk. So although we were very fixated with forecasts, the personalised triggers is almost a more important feature to end users. So we knew we needed to attend a lot more to that in the data analytics than we were originally thinking about. And these user insights have fed directly into our kind of data science stream. So Naweed in the room is and Matt are focusing on this idea of seizure detection. So whereas seizure forecasting is telling you your likelihood of risk in the future, seizure detection is an algorithm which can detect if a seizure is occurring at this moment in time, and that can really help with that quick reporting of the events. So there are some existing seizure detection algorithms out there at the moment, and one of the problems is there's quite a lot of false positives. So we're still having user validation, but the idea is that detection algorithm will be integrated with the Garmin. It would passively detect a seizure, and then users can just validate yes it was or no it wasn't, just to aid with that with the ease and quickness of reporting. And as I mentioned, we weren't so focused on the personalised triggers, but we realised that's something we was really important to explore in the data science. So using kind of SHAP and feature importance techniques, that's something the team are exploring. And then the other bit that came out from users was around self-management support. So things like giving them information on how to manage risk, how to manage personalised triggers. And a lot of people brought up actually, often this isn't the most important thing, but actually having more therapeutic support or wellbeing support can be extremely stressful to have a seizure, and having some kind of therapeutic support immediately after a seizure could be like quite reassuring and be quite a valuable element of the app. But the key thing is this is really personalised. So some people early on in diagnosis, when they haven't really learned about that they're not well versed in their condition and they haven't learned a lot of coping strategies, these are really important. They might want or need a lot of information around this. Whereas later on in your condition, you might have kind of learned how to manage your condition quite well, and ongoing mental health support becomes more important to you. So the idea that this self-management is personalised and flexible to your needs came out as quite a critical user requirement. So as a team, we're also exploring the value of using LLMs to deliver this more adaptive support, both in explaining the forecast to make them more interpretable, but also to provide this tailored and targeted and flexible self-management support. And another key requirement, so early on in the co-design, and something that people with epilepsy and clinicians came up with, is that we'll be collecting all this out of clinic data, and that will be fed back to the user in their app. But there's also real potential to use this out of clinic data and give it to clinicians, for example, in an NHS clinical dashboard, to help with clinical decision making within an NHS pathway. So, for example, it could help with triaging, so really identifying people who are stable and well, and maybe they don't need to come in for an appointment, and that could be pushed back a bit further. That would make appointments more efficient for the NHS, but also less burden on the patient having to come into hospital when they don't need an appointment. But also noticing when people are deteriorating and maybe having an increased number of seizures or increased side effects, and they can be called in for earlier intervention. And then also within the clinical appointment, if you have a sense of seizure trends, so are they increasing, are they decreasing, are they having side effects from medication, this can much better inform your clinical appointment. And one of the reasons why this out of clinic data is seen as so valuable is because often within specialist services, appointments can be like a year apart. So the patient will come in and the clinician will say, well, how's your epilepsy? How's the medication management going? What are your side effects like? And for anyone, it's really hard to recall what has happened in a year, let alone if you're experiencing cognitive impairment. So it really gives much richer data about what is happening in between those appointments, where currently there's kind of very limited data available on that. And Amelia in the team, her PhD is really focused around what are the core requirements for this dashboard, what are the key features that clinicians want, how do they need to, how does that data need to be presented to aid that collaborative decision making. And yeah, I won't go into that. So just as a kind of roundup of the methods, really. So as I mentioned, we in this team, we really took an interdisciplinary approach. We weren't just thinking about those kind of core engineering questions from the beginning. Although the data science is really the fundamental element of the project, we really wanted to start exploring all those complex end user and complex systems issues early on. And with our user-centered design and in-the-wild approaches, one of the key things there was moving to in-the-wild deployment as soon as possible. This gave us a much better insights into how the technology would be used by users rather than kind of staying in lab testing for a long time. It also allowed us to maximize data, which was really critical for this technology, but other kind of technologies that rely on this kind of real-time data, moving to data collection as quickly as possible is really valuable for the data science component. And then always trying to keep sight of the clinical problem, because it can be really easy to get very focused on like what's the performance of the algorithm, which obviously is critical, or how can we design this like forecasting visual to like make sure that it's really explainable to users. But actually it can be a great, like the algorithm can perform really well, and you may have a forecasting visual which users understand, but if it doesn't actually support them to then take action, this is not actually going to translate to clinical outcomes or impact on the NHS. So always trying to hold that kind of wider problem in mind, think of other features that you need is really important. And yeah, just their interdisciplinary nature and that kind of cross collaboration between the work streams, and having findings from the data science feed into the HCI packages and vice versa has been kind of a really critical element of our project, which I would suggest is critical for most projects with this kind of user design. Well, yeah, I thought that screen going black was signalling the end of the talk. But yeah, yeah, end of talk. So thanks very much.
Do we have any questions in the room first of all? Please.
Could you go back to the user-centered design one? Yeah, that one. So could you talk a bit more about the voice reporting one and the visual tracking of input?
Okay, yeah, so the voice reporting this was something that we're exploring of. So at the moment, we're exploring different ways to use app features to enable like one-click reporting. So we were thinking about, can you report it with a click from the smartwatch, because people don't always have their phone next to them? Can you do one-click reporting from a home screen rather than having to go into the app? But something that our users have flagged up is like often people use voice notes. So instead of having to go click into the app and like click buttons to report things, you can actually use voice reporting to say that you've had a seizure and document it that way. So that's like seen as like a feature that like some people have reported they can do straight after a seizure, and it's something that they're already doing. Like they'll often, one user talked about using voice notes to record details of their seizure, which they then share with their clinician. So we know this is something that users are already doing as part of their management. So we wanted to explore whether that would kind of be another feature that would enable ease of reporting. And then the visual tracking was that because of cognitive impairment, people were often forgetting whether they had recorded a seizure or not. So then they would go back into the app to report it again, but they couldn't remember if they already had. So there was no visual prompt of what they had already logged. So we created this design where there's like basically like Outlook calendars, where it logs everything that they put in the app. So they can also it helps them with tracking as well, because they can see when they've had seizures, if they're increasing over time, decreasing. So they've got a log, but it's also that they can see on that day, have they already logged a seizure or not? And it's just kind of like a visual prompt, so they don't end up logging it like multiple times.
So obviously I can't need some, I'm not sure if I missed something, but are you using a watch as well?
Yeah, so it's a Garmin, so commercially available smartwatch.
Have you not, like, have the scientists not found anything to actually kind of automatically tell you that they are having a seizure?
Yeah, so this is so with the seizure detection, so kind of is there a way to use the Garmin to detect if a seizure is occurring now? Was that the question?
Oh, yeah.
Yeah, so this is the issue around passive seizure detection. So there are some existing open access algorithms that use heart rate variability and accelerometry to so they use like a compound measure to identify if a seizure is occurring. There are real limitations because it can detect tonic-clonic seizures. So they're the ones we typically think of when we think of epilepsy. So they're the kind of ones that they used to be called fits, where there's kind of like repeated like motions, like bodily motions, and it's quite good at picking that up through the accelerometry and heart rate. It's not very good at picking up other type of seizures, so things like absences, where there aren't kind of that activity patterns, and it also generates quite a lot of false positives. So people will be doing other actions, and it kind of like flags it as a seizure. So there are limitations, and we still need to do user validation. But if you're interested in that, Noid is working on that element. So yeah, is there anything else to say?
No, I mean, and you want to make it more personalised, which is why they're taking the data from each individual person, and some of the existing like seizure detection might actually be more general.
Yeah. Thanks.
On that, are there any sort of indicators to see if a seizure is about to happen, not if it's happening already?
So are there any existing technologies which are doing forecasting?
Yeah.
Yeah, so the detection is that what we're using to label our data. The entire purpose of the project is that forecasting. So what's the likelihood of seizure in, say, the next 2 hours or the next 24 hours to give that risk score? There are some technologies that are exploring that. So there's something called Unique, which is an implantable device. So it requires neurosurgery, it's implanted, and it's actually directly monitoring brain activity. So where our modelling is based on using triggers to create a risk score, that's actually using like early warnings in the brain activity to then create a risk score. But the problem is it can only be used with, it's not very scalable. There are only so many patients that can go in for invasive surgery, and it's not, it can't be used over the long term as well. So the implants have to come out and have to be changed. So it'd be a really expensive solution. And so this is the idea that this one's more accessible and scalable because it just relies on smartwatches.
Have you found any indicators that sort of show it yet, though, through the data that you've worked on?
Indicators and what sense? Like the sort of features?
Yeah, any features there?
I mean, I think it depends on also the different type of people, because the lead data scientist, Leandro, I think there's been a lot of focus on like, there's been a trend in seeing that's quite a lot to do with the circadian rhythm, which is related to someone has a seizure or not. Or like the monthly cycle, so different features for different people, especially for different types of seizures as well. Since Amberly was saying that there's a tonic-clonic one, there's also other seizures, and those other seizures might be related, like might be more affected by other features.
So are you saying, have they actually found any like accuracy in the model yet, or like what's the performance in the model? So they've started translating to real patient data, and it's really variable. So there was like, so we've got 14 users that they've been testing it in. There's one where it predicted with 90% accuracy, and it was really driven like by physical activity markers. So you're like, oh wow, but then for others it's like the same as chance. So it is like variable, and so they want to do further work as well as like identifying for which users is this like better at predicting. Like there are certain epilepsy types where it's like 90% driven by the menstrual cycle, for example. So if you have that data, you can get a really accurate score. Whereas for other people, it seems like it's much harder to predict from triggers. So yeah, at the moment, like they're definitely working on optimizing it and working out who it's like which subgroups this is going to be most accurate for as well. Does that answer?
Yeah.
We have a question from online from Henry Hickson. great talk, thank you. I may have missed this, but does the data collected in user trials feed back into the prediction model?
So the is that the data collected from the data collection component? Is that the question? So. Yeah. So we were working, like, all three work packages were kind of done separately and in parallel. So with the data collection component, we tried to get that from co-design to like real world deployment as quickly as possible, so that we could have a data stream coming in from people with epilepsy over the long term, and that was being shared. I don't quite know, and that was being shared with the data science team as early on in the possible, so that they could move from modelling on synthetic data sets to actually modelling on the data structure that we collect through the Garmin and the companion app. Is that yeah?
Great, thank you. First month.
Okay.
Any more questions in the room or online?
So, moving aside, maybe more towards the patient app, like, what informed that design? Or because I know, like, people with like epilepsy, they're sensitive to like colors and flashing lights, or is there any like reason why you chose that color to like relax them or anything like that?
Yeah, that's a really good question. So we did think about red, amber, green as like the risk scoring, because that is kind of universally like a very clear indicator of risk. But there was like we were slightly worried about using red because it can like elicit a stress response, and as mentioned, that can then turn into this feedback loop that you've kind of induced stress from a high risk score, and that's actually a trigger within itself. So we did move towards some designs using purple because one, it's better for colour blindness, but we were thinking this might actually reduce the risks around presenting red like as the warning sign. But we are actually moving away from these designs of just like a one static time point to more longitudinal designs. So they're actually kind of seeing the fluctuation of their risk score across the day. So yeah, that I don't have images of it, but so what informed that? So it was we looked at other apps and how they had presented risk scores, and then we kind of created a whole range of visuals, and then we went into user testing. So we just had some kind of structured questions that we asked them about interpretability, what they thought the emotional impact would be, what additional features they need, and then we were kind of iteratively using that feedback to kind of change the designs. There was another part to your question, but I can't remember what it was.
Any more online, Emily? Or we should wrap up if everyone's still in the room?
Yeah.
Yeah, great. Well, yeah, you go around and close.